Hello everyone, welcome back once again to the PriGina Medical YouTube channel. Today we are going to talk about infantile hypertrophic pyloric stenosis, another high-yield topic that appears in the USMLE exam. To define pyloric stenosis, we are going to simply explain this as an obstruction that occurs between the stomach and the small intestine. So there's an opening between the stomach and the small intestine, which is known as the pylorus. So when that point becomes obstructed, it becomes narrowed to the extent that it becomes very difficult for food to pass between the stomach and into the intestine. So as I was describing earlier, there is going to be a thickening of the pylorus leading to gastric outlet obstruction. So no food is passing, or just very little amount is passing between the stomach through to the intestine. And it's important to know the age range for this disease. So usually infants between the age of 3 to 6 weeks are at high risk of having this condition. Okay, let's see the risk factors. So first we will talk about macrolides, example erythromycin. So there's very little known about how this happens, but then studies have shown that macrolides stimulate gastric motility, which can lead to abnormal contraction of the pylorus, hence leading to infantile hypertrophic pyloric stenosis. So that's the little known about how macrolides could cause this condition. And then genetics might play a role because firstborn male infants are at high risk of the disease. Also, formula-fed infants might be at high risk because formula-fed infants usually have slow gastric emptying. So when this occurs, there's usually an increase in gastric burden, and hence this would cause a stimulation of pylorus muscle growth. Let's discuss the clinical presentation in pyloric stenosis. So for symptoms, most of patients might report with projectile non-bilious vomiting. So non-bilious vomiting often occurs because there's obstruction proximal to the bile duct, as compared to bilious vomiting where the obstruction is distal to the bile duct. So this projectile non-bilious vomiting usually occurs right after feeding, and right after this occurs, the infant usually gets hungry right after the vomiting. So they are usually called hungry vomiters. So in most of the cases, the clinical scenario will paint a picture of a child who is interested in feeding right after vomiting. So kindly watch out for that. On exam findings, you are going to find signs of dehydration, example absent tears, sunken eyes. Also, there is going to be visible peristalsis, sometimes on physical examination. So visible peristalsis appears as waves of movement across the abdomen, which is usually a sign of intestinal obstruction. You may also find a palpable olive-shaped epigastric mass on physical exam. Lab findings include hypochloremic, hypokalemic, metabolic alkalosis. But note that labs may be normal at an early stage. So this is an important lab findings and a very high yield question usually asked under pyloric stenosis. I'll describe this further in the next slide. There could also be an increase in bilirubin levels because portal system compression might occur due to the intra-abdominal pressure occurring from the increased contraction of the pyloric muscles. Let's talk about the lab findings. So persistent vomiting would cause a loss of gastric hydrochloric acid. This is how metabolic alkalosis and hypochloremia starts. Also, when you vomit, there is going to be loss of sodium chloride and water. Patient is going to be hypovolemic, and underperfusion of the renal system is going to occur. So as a way of compensation, there's going to be an increase in angiotensin 2 levels, which is going to cause an increase in bicarb reabsorption and an increase in aldosterone levels, which will lead to increase in hydrogen secretion as well as potassium secretion, therefore causing hypokalemia. So this is how metabolic alkalosis, hypochloremia, and then hypokalemia end up occurring, leading to that electrolyte imbalance that was discussed in the previous slide. Now, the best diagnostic test for this condition is ultrasound. On ultrasound, you are going to see a thickened, elongated pylorus, as seen in the next slide here. So this is the stomach and this is the pylorus. When you go down, you are going right into the intestine. And this is the thickened, elongated pylorus that is causing a narrowing of the lumen here, or an obstruction as seen right here. Now, how do we treat pyloric stenosis? So it's important to always make sure that patient is on IV fluids and well hydrated, as most patients present with dehydration. Always correct any electrolyte depletion. And then finally, surgical pyloromyotomy is done. So this surgery is done in order to make a way through the pylorus or make an incision in the wall of the pylorus to relieve the obstruction. Let's discuss some questions. A 5-week-old boy is being evaluated for postprandial projectile vomiting. The patient seems interested in feeding again after each episode. Patient was noted to have decreased skin turgor and capillary refill, and also a peristaltic wave was seen on the upper abdomen on physical exam. What is the next step in diagnosing the condition? So as we described in previous slides, this is a patient that has projectile vomiting after feeding. And it's important to note that the question says patient is interested in feeding again after each episode. So this is a hungry vomiter right here being described. They also gave us signs of dehydration, of decreased skin turgor, and decreased capillary refill. And then visible peristaltic wave are seen on the upper abdomen. This is clearly infantile hypertrophic pyloric stenosis being described here. The imaging of choice here is going to be an ultrasound of the abdomen. We never give antibiotics, neither do we do a CT of the abdomen. So the next question says, what acid-base electrolyte imbalance will be found in this patient? We learned that hypokalemic, hypochloremic metabolic alkalosis is the acid-base imbalance that is seen in these patients, because patient is losing hydrochloric acid, patient is also losing sodium chloride, and as a way of compensation, there's going to be increase in angiotensin, increase in aldosterone levels, and then as potassium secretion increases, there's going to be hypokalemia. So we've described all this in the slides, just in case you want to take a look at it again. So the next question says that what is the best next step in managing this patient? So our main aim is to always replete electrolytes and stabilize patients by giving IV fluid even before surgery is going to be done. So finally, we are going to do surgery all right, but make sure that patient is always stable. So that's why we chose this answer. We have come to the end of today's slides. I hope you enjoyed this lesson. We hope to see you in the next one. Thank you and have a nice day.